Fantastic. Look, thank you very much, everybody, for joining. I can see that the participants room is filling up at the moment. As you would have seen in the invite, topic for today, adapting the trends for pharmaceutical executives. And joining me, I've got Vishnu from Spectrum Health, the chairman and co-founder, along with Nazmi, the CEO of Doctors & Co. Really sort of objective for today, basically with Rextro, what we're running here is a online system that really connects the time that general practice makes available for educational opportunities with a wide industry of people that are obviously booking in to utilise those opportunities. Really sort of purpose for today, jumping on with a couple of experts just to understand sort of the current trends that are happening and really sort of exploring in depth those pieces. But before we jump into things, it'd be great to just get a little bit of an understanding of both of you and your background. So maybe Vishnu, to start, if you could just give us an overview of your background and how you ended up as chairman and co-founder of Spectrum Health.
Thank you, Liam. Good day, audience. I'm Vishnu Gopalan. I'm a general practitioner by profession. I'm a practicing general practitioner, and we started our company back in 2013. We have about 45 clinics in Western Australia, predominantly in Perth and a few regional sites. We have about 250 GPs working in our organization, and life's been really good, albeit challenging times with doctors recruitment and doctor shortages and whatnot, which we will touch about those topics as we go along. Recently, I have foraged into technology as well. I am also the co-founder and chief medical officer of a company called Hola Health, which specializes in a very unique on-demand style medical consultation with a doctor, and we also do the medicine delivery to complete the cycle of care for the patients. Thank you.
Fantastic. Thank you. And Nazmi, maybe if you can give us your background.
Yeah, well, it's exciting to see the story of Vishnu. So my name is Nazmi Misami. I'm the CEO of Doctors & Co. We're a group of GP clinics across New South Wales, Queensland, Victoria, and ACT, mainly the East Coast. Currently 43 clinics, just under 300 GPs, full-time equivalent in our group. We've started with one practice about 6 years ago, and we have just been opening clinics since then, working with like-minded doctors who really value healthcare at a larger scale to the community. We've got regional and remote clinics, so we've sort of captured a fair bit of the demographics to care for. And yeah, we're just enjoying growing with the teams. That's it.
Fantastic, fantastic. So look, on the line, as I say, really aimed at a sort of pharmaceutical audience. I'm pleased to say that we've had over 50 registrations and really a representation from the senior management of most of the major pharmaceutical companies. So yeah, really looking forward to the next half hour with you guys. For people that are on the line, what you'll see is there's a Q&A button on the bottom of Zoom. Please ask the questions at any time as they come back. But what we might do is obviously make sure that we get through the main key trends and then at the end sort of come back to deal with those specific questions. So look, probably before we jump into the specifics, I'd be really keen to hear from both of you. At the moment, obviously you guys are operating large groups of general practices. What do you sort of see as the main challenge and really the main opportunity in primary care at the moment? Maybe if we start with Vishnu.
The challenge has been the funding for quite a long time. The Medicare rebates have remained frozen for prolonged periods, not matching with the CPI and whatnot, and they were raising costs and so on. And obviously, Nazmi would also relate to this. There's been a big shift into mixed billing practices recently, which has kind of helped us to keep our models going forward. And there's just not enough GPs in the country, to be very honest, let it be cities or regional for that matter. As you can see from the latest report released from RACGP, the average waiting time in cities is about 3 days, and in regional areas, it could go up to even 2 weeks. So people with acute problems are not getting timely care as we speak. So getting more doctors under different pathways, which RACGP have started recognizing and kind of making that happen is good. But at the same time, there was a very scathing Crook report, which lambasted RACGP and APRA for all the processes that were really time consuming and obsolete methods, and the cost to get your qualifications recognized in Australia is 5 times more than that of Canada or England. So that's been a major hurdle for a lot of these doctors aspiring to come from Bangladesh, Philippines, and Malaysia, and so on. But things are in the right track. We are doing some good things to make that easier for these IMGs and attract some good quality IMGs. So I think the next 2 to 3 years, I can see some improvements in the system.
Fantastic, fantastic. And just to qualify, Vishnu, with IMG, you were talking about international medical graduates.
Medical graduates, yes.
Fantastic.
That is our GP parlance, so forgive me.
Oh, good. No, fantastic. And Nazmi, really keen to hear your thoughts around that as well.
Look, I personally see the shift. While look, to top up what Vishnu was referring to, I agree with him. This is one major problem that we're seeing in the industry, and it's slowly improving. The government's recognizing solutions. Where I'm seeing bigger shift is two aspects in the industry: doctors' mindset and the patient's mindset. Patients now are looking for convenience. They're no longer just looking for face-to-face consultation. We saw this with the introduction of telehealth throughout the entire process throughout COVID, and it carried on with a lot of these private services. So the pool of patients that was visiting a GP with a week or 2 weeks or 3 weeks waiting time now is slowly shifting towards other different type of services. We saw that same also pool of doctors offering that face-to-face consultation is now exposed to different specialties in the market. So they're no longer just doing GP work. They're actually general practitioners, but they're offering specialized GP referral services in no longer just in one scope practice. So there is a bit of a confusion of how the market is adjusting to it. And this is where I believe, everyone is trying to tackle that, introducing virtual clinics, specialized practices, GP clinics, sustaining it financially to make it align in work. So, the challenge is not just no longer GP recruitment. A lot of clinics are now looking for alternatives. They're looking for, services that could be run by nurses or nurse practitioners, which is taking a bit of piece of the pie. If we keep scaling it in that pool, it's no longer just one focused general practice, while we're still dealing with the same role, general practitioner.
Absolutely. Because it sort of ties into one of the things that I was interested in, obviously, in having sort of separate conversations with both of you was obviously you both talked about telehealth and convenience, but I'd really be keen to hear more, maybe just staying with you, Nazmi. I know you sort of spoke about kind of aligning your telehealth in kind of regional areas to sort of metro GP, but maybe do you want to just give us a bit more insight around that?
Yeah, so we are running a virtual clinic very similar to the clinic that Vishnu is running. It's called Zali Health, and we've been managing to capture a fair bit of patient referrals from regional and rural areas to our closer to the city clinics, where it's easier for us to recruit doctors. And the type of patients that we've been seeing is just general medicine type of thing. So which a lot of patients refer to the 5-minute consultations. In the market that we're in, unfortunately, some doctors like to see 50 patients a day. Some doctors like to see 40. Some of them like to see 30. So the level of complexity on the patient is what we realize there is certain caliber of patients that we've been missing out in the clinic, and that would like to bring them back to the practices and applying this to redistribute the services and the workforce that we have in Australia. So Australia is a very funny market in healthcare, and this is just my humble opinion. In some areas, there is an overflow of GPs. In other areas, there's just a huge shortage. Doctors like to move in where it's closer to the beach, closer to nicer areas, best schools, best views, close to the airport. We all like the convenience. Let's be honest about it. So, doctors are finishing in their qualifications in regional remote areas, and they're shifting to the metro. So unless we are creating a systematic plan internally to maintain that growth of services and keep maintaining that supply in regional, we're just going to always end up with the same leak of problems. So yeah, it's a shift of services and shift of workforce that you see carrying on. So we thought it will be easier for us to manage this through telehealth with services, things that it's already available in the market by many operators. But the focus is just depending on where they're funding. So, some areas and catchment areas have got bigger funding, therefore they've got bigger access to the service. Some other areas have got zero funding, depending on the primary health network they're involved in and how they want to cater for that service in their locality. Ultimately, I believe, with the introduction of private clinics or a lot of GP clinics changing from bulk billing to mixed billings, patients are now saying, well, I don't want to pay for bulk billing service plus a gap fee. I would rather go and do a telehealth and just pay the gap fee without the need for a wait for another 2-3 weeks to get the same level of service that I would like to align. Obviously, patients are no longer just looking also for one type of doctor. There is a doctor that's doing medical certificates, there's doctors doing for them repeat scripts, and there's doctors that are doing for them the actual care where they'll be happy to pay a gap. So if you tick the boxes, bulk billing, and then mixed billing, if you put it in this way, yeah.
No, absolutely. And look, Vishnu, I know that you're obviously doing a lot of similar stuff on the other side of the country. I remember when I was sort of speaking with you, you were talking about it as well from a doctor's point of view. So obviously being able to log on, log off, giving that flexibility. I'm really keen to hear more about how you're doing that with Hola Health.
So yeah, we foraged into Hola Health, and we initially started with medicine delivery and soon pivoted into telehealth, and we operate Australia-wide. So our service is completely private, so there's no funding whatsoever. The patient pays the full fee. Obviously, there is no Medicare rebate for that. And we are, I would like to say, a true Uber-style platform. So we don't have appointment times. We promise a GP within 15 minutes. The way we are able to do this is because I thought of a plan whereby we could unlock all of our GPs' free time. So, all our GPs, have an app. I'm sure all of you have used an Uber before as a customer, but most of you will also realize that the Uber driver has a separate app where they are able to toggle on, pick up jobs and toggle off. So we built a similar app for our doctors. So when they have an appointment cancel and they have a free time of 15 minutes or 30 minutes, or if it's their lunch break or tea break, they're able to toggle on, do 1 or 2 consults, sometimes 3 or 4, depending on like Nazmi said, it's just repeat scripts or med sets and so on. Now that we are doing synchronous consults, obviously you can't just tick the boxes and keep going on. You have to actually speak with the patient and so on. So we've been able to unlock the doctor's free time. Plus, when they go home and they don't have a lot to do, they just toggle on, work for an hour and toggle off. So that is how we've been able to render all these consults. And in the last quarter alone, our waiting time was on an average 5.3 minutes. So we have been able to do those consults with that wait time, and we roughly do about 1,200 to 1,500 consultations per day. So, we have to come up with different mechanisms and methodologies to unlock the GP's free time, whereby we are able to render these consults. And we did an audit, and we still found that 70% of our users are actually from capital cities, only 30% from regional areas. And slowly we are seeing a shift in patterns, where there is more pickup in regional areas. And like, Nazmi alluded to, virtual clinics are the way to go, because even the international doctors are not so keen to go to regional areas. And to some of our listeners, I'll pick up a couple of remote areas from Western Australia, like, Karratha and Port Hedland, which are big mining towns, massive presence with, BHP and Rio Tinto and so on. There's a lot of work to do, and there's a lot of private work, including, pre-employment and, the medical checkups and so on. But doctors just don't want it. And again, like Nazmi rightly said, they want locations, where there's a mosque, or where, there's good schools close to the beach, nice 4-bedroom mansion overlooking the ocean, you know. So when they start to have all those kind of criteria to choose their location, then, the amount of places become thinner and thinner. So these are challenges. But then again, there are some hardworking doctors who would like to go and really work in the country to experience a different lifestyle. And yeah, like I said, in the next 3 to 4 years, we can see an improvement in the waiting times.
Oh, absolutely, absolutely. No, look, I think it's definitely a real change, obviously, from really in the last sort of 5 to 10 years, through from 100% sort of bulk build or 89% bulk build in a face-to-face consult room to obviously telehealth, and then even a portion of telehealth that is just a private fee. But if I can get on in 5 minutes, then obviously the patient's obviously prepared to pay it. Maybe just shifting through. One of the other things that we sort of see that's coming out in the Health of the Nation report is really sort of reports from GPs around GP burnout and so forth. And I think this probably tied into a lot of what one of the big themes that I'm hearing from you guys is around the recruitment. There's sort of stats that are thrown around, sort of 30% of GPs are looking to retire in the next 5 years. The desire to own a practice has gone down, so you guys are sort of reducing the number. Really kind of just keen to hear your thoughts around those two. Maybe Nazmi, what are your thoughts around that?
Look, it's a complicated issue in the industry. Everyone is sort of ambitious about owning a practice and understanding that operating a clinic is just simply recruiting doctors and operating it. But the matter of fact, there's a lot of compliance behind it. The bigger fee that a lot of doctors always deal with is compliance, APRA guideline, RCGP guidelines, the indemnity side of it with the patient, providing quality care, and maintaining financial stability for their income. Okay, there's the 6 main factors where I see it's always a risk, and that obviously diversifies the level of prescribing for the doctor, the level of care that they offer the doctor, and ultimately the type of service they can offer to the patients. Okay, so we see this as a trend. In the last couple of years, you see doctors shifting from mixed billing to now, with the increase of the bulk billing rates, a lot of the clinics now are shifting back again to bulk billing. So I believe in the next 12 months, you will see patients are no longer financially able to afford general practitioner service because they would rather put this money towards something else because of inflation and many other factors. So the level of focus for the patient now is about saving money and putting it towards something else. Personally, I no longer see general practice as just standard medical. Now it's medical, healthcare, or health or and well-being. So there's 3 different spectrums of the market, which defines the level of prescribing for the doctor to the patient, and ultimately funnel to what pharmaceutical companies want to see from the doctors. Yeah, in simple terms, yeah.
Absolutely. And Vishnu, your thoughts?
Yeah, in terms of owning a practice, the verve is gone down because 15 years ago, you in a clinic you just needed a unisex toilet and a disabled toilet, but now you have to cater for the LGBT community. There are specific guidelines, and if you don't do that, you don't get the accreditation. And Nazmi can definitely agree to this. In the last 10 years, the accreditation for practice has become so difficult. It's just adding layers upon layers of complexity, and it all falls down on the GP's head or the practice owner's head. And the onus is on the practice owners to pick all of that and still keep going with the model. So it's just easy to be a contractor, rock up to work, finish your work, and go back. So that's one of the key drivers. Plus, again, like I already mentioned, there are rising costs for everything, which makes it a bit unattractive for young doctors to aspire to own their own clinics. It's still happening, but I agree with the report. The level's gone down.
Sure, sure. And I guess probably final question before I sort of open it up to people, and I can see there's a few questions up coming in here. One of the things, obviously, I'm really keen to understand more of, obviously, with Rextro, it's a platform to facilitate those in-surgery education activities that occur. Speaking with both of you, I know that one of the big things is that you've got very kind of plans around sort of your staff training and processes, and a really key part of providing a stimulating working environment. Maybe just you first, Nazmi. I was keen to, I know that we were discussing sort of, how you plan it out. Maybe if you could share with the group that one.
How do you plan out what, Liam, exactly?
So you were talking about you were at an in-house nurse educator and you were looking to have different themes and clinics and so forth.
Yeah, so when you're talking about aligning the market, a lot of doctors want support. A lot of nursing staff need support. If we're relying on overseas trained doctors, they're not really introduced or they're not really educated about MBS guidelines and educated about clinical guidelines or even the minimum requirements to provide quality care. Every country they come from, they come in from a different system. So the adaptation space between them joining to potentially building up that level of confidence beyond just the clinical side of it, just introducing them to the Australian healthcare system is about 2 years to 2.5 years. And that's generally how long they need to jump in from limited registration to provisional to general registration to potentially maybe apply for their fellowship program to be potentially unrestricted GP. So having a nurse or nurse educator or a medical director that would lead that practice in various aspects will clearly improve the quality of the care offered in the clinic, maximize the level of support offered for these doctors, and ultimately support them to train them and upskill them, specifically in the general requirements of the health promotion prevention. If I look at, a lot of pharmaceutical companies that we work with, they come into our practices and they come in randomly for a nice lunch, and doctors will sit down and enjoy, have a bit of a nice chat, and ultimately enjoy maybe a nice kebab most of the time. But the reality of it, how effective was this training offered for these guys in a very busy schedule in a day? It will be very, very minimal. So, we saw a better engagement within our team of doctors and nurses when we introduced the medical director role to upskill them and train them and educate them, and with the support of a nurse or nurse practitioner as a nurse educator.
Oh, absolutely. And I know that you were sort of talking about there's a sort of curriculum that you guys have even put together around different therapy areas for different months. Is that right?
Yeah, exactly. So we simply follow the health promotion prevention guideline for the government. Okay, this is just how I simply adapt the doctor's mindset, and also the clinic to operate, generally speaking. So let's say we're targeting 2 or 3 clinical conditions for February, for the month of February, for example. We follow what the government is telling us we need to follow. We align our marketing to our clinicians, to our doctors, to our nurses, to ensure that we're recalling these patients. So when we are getting pharmaceutical reps coming into our practices, we tell them, okay, what is your medication? What is it targeting? Okay, it's not the focus for this month. In 9 out of 10, we find them, trying to introduce a medication that we probably don't want to sort of push for that recall cycle of those patients. At the moment, across our practices, just that exercise of health promotion and prevention is bringing close to about 40,000 patients every quarter in our clinics. Okay, this is just simply from health promotion and prevention, which is something that triggers a lot of the repeat scripts, introducing patients for another assessment and the like of such cycles. So more than happy to sort of walk you through the entire year, and then you will sort of see how we work as a practice. So whenever anyone comes into our practices, we tell these reps, here you go, this is our annual cycle. Come to us next month with this focus, so we can align you with our clinicians and for the patients. So just aligning the whole focus.
And yeah, Vishnu, keen to sort of understand more about your approach to sort of ongoing education and training in your practice.
We're slightly a bit different, but the crux is very similar to what Nazmi mentioned. So we are encouraging our GPs to find other avenues. For instance, medicinal cannabis is quite popular now. The RAC GP has introduced a new course in lifestyle medicine, which is a proper 2-year diploma. So we are encouraging our doctors to pursue different things and try and support them, because I find this, in 4 to 5 years, like you said, it's going to be a holistic care. Guys who are going to come who want purely non-pharmacological methods for weight loss. Currently Ozempic and Mounjaro are very popular. Maybe in 5 years, there are going to be some studies that are going to come out and they are going to go away from these injectables and want, more natural things. So we are trying to identify those things and create different streams. And again, very similar to what Nazmi said, trying to create individual specialties and disciplines within general practice so that there is cross-referral between the clinics so that we can try and retain the patients and, give them all the services that we possibly can.
Fantastic. Well, look, what I might do is obviously open up to questions from the audience, and I can see that they are starting to come through. So I'll sort of bring them into themes. But look, probably the big one, and it's come through in a few different questions here. Obviously, the audience at the moment, a pharmaceutical audience, and the big question in my mind. There's one question that says, within your practices, how do you see pharma working best with your clinics? And obviously, how does that sort of work? What do you sort of see pharma's role as private support to you guys? Maybe Nazmi first.
Personally, identifying the key areas, geographical areas where there's larger concentration of doctors, events on monthly basis with the coordination of PHN, targeting and tying up that event with the health promotion prevention for the government, because then you will see that you're working in synchronous with what the government wants to achieve, what the primary health network wants to achieve for their funding. And ultimately, the practices will benefit from increasing their SWIP and introducing their incentives that they get paid for every quarter. So if you're aligning that part of it and engaging it not just at a single practice level, if you're doing it at a single practice level, relying on the possibility of having the entire team available to introduce what you do. So what we always do every month, we offer our teams 2 hours a month paid to go actually to train on a certain topic, and mainly in that health promotion and prevention. Costs us money, yes, but we see the return on investment for us when we are increasing the number of patients coming to the practice. So for us, it's a cycle that we saw improving the quality of our doctors as they sort of offer the service to the patients.
Fantastic. No, so I guess probably what I'm hearing there, Nazmi, is just alignment between what you're trying to achieve, what the doctor's trying to achieve, and even the PHN and obviously the government initiatives as well.
Yeah. Well, look, the challenge, Liam, and you see it across the board. A lot of doctors are just too busy to run the business. So Vishnu and I were lucky that we're actually involved. We know the ins and outs of a business. We can look at the business and know where's the gaps in a business. But the reality of it, majority of the doctors don't have the time, don't have the capacity to sit down and think about these little solutions, which ultimately, pulls into growing the practice, in maximizing what they do day to day.
Fantastic. And yeah, keen to hear your thoughts, Vishnu. And there's another question that's come in around that's obviously the role of pharma, but also just around, do you prefer it to be delivered by external providers such as a local specialist or so forth, or do you see that pharma delivery of education as important as well?
It really depends. We did an audit not so long ago, probably about a year ago, where our GPs are not that interested in lunchtime meetings because, they don't really need to increase their patient base because they're already so busy. And in their minds, their practice is running well, they're keeping up with their CPD points. It's something like, if it's not broken, why fix it kind of stuff. One of the patterns that I'm seeing is with the young registrars coming through RACGP, they are more keen to learn, they are more keen to adapt to technology and are more reciprocative. But with some of the older GPs, probably they are in that group where they want to retire in the next 5 years. They're just happy to chug along. So it is very difficult to capture the GP's attention in the current scenario. I don't know what's the best answer, but definitely with CPD points and those kind of things is a big attraction for GPs because they get to tick off some boxes with their CPD activities and learning and so on. And again, with some pharma companies, we see For instance, I'm not going to mention any names, but there's a certain product in the diabetes portfolio. They're there 8 to 10 times a year, right? It's the same drug. It's not going to evolve every 2 months. GPs know that, these are the criteria. This is the authority required to prescribe this. This is the cutoff where you can initiate. So overloading them with informations like being in their face can sometimes be counterproductive. I don't know the answer to this, Liam, but generally GPs are less reluctant for lunch meetings these days, as opposed to when I used to be a registrar back in 2008, 2009, thereabouts.
Oh, absolutely. Absolutely.
There is just one question for me specifically. I'll just take it if you don't mind.
Yep.
So are virtual GPs employed by you, or they are independent and paying a fee? Yeah. So we started by leveraging into GPs working in Spectrum. So currently we have about close to 95 GPs nationwide, and out of which probably 45 to 50 are outside of our organization in different parts of Australia. So like just a normal clinic where as a contractor they get a percentage, we do the same at Hola Health as well. Thanks.
Fantastic. Fantastic. Excellent. And maybe, look, I'm conscious of the time, and thank you very much, but we might just have one final question. Just really keen to understand. So it's just come through that the feedback that sort of industry is sort of hearing is obviously there's a lot of challenges around the new shift to the RACGP model and CPD hours. I guess firstly, is that something that's consistent with what you're hearing? And if so, sort of once again, do you sort of see a role of industry in sort of supporting that at all? Maybe Nazmi, firstly, is that consistent with what you're hearing, or your doctors all across the CPD?
Yeah, doctors now they're a bit burned out from just doing mainstream general practice, and ultimately, they might see 40 patients a day, but a lot of it, probably 10 patients that need their clinical skills, and the rest of it probably could be managed in various ways. The reality of it, we're seeing a big change in the doctor's mindset towards just doing mainstream general practice. So now they see some GPs, they were told, I just want to do medicinal cannabis, I just want to do women's health. I just want to do telehealth, and you see that difference between female GPs to male GPs, different age groups, and different training requirements for each program or each diversity of specialty that they want to target. The bigger focus now is just where do you draw a line? Where is general practice heading in the next 5 years? Vision and I probably we're going to sit down and talk about this for probably a week. We're no longer seeing patients are coming through the door for one problem. They're coming in for various problems. But that patient that is coming for one problem, is coming in for they're going to other clinicians to get treated for other conditions. They'll not be treated by their regular GP. Yeah.
Fantastic. And maybe just final word, Vishnu.
Yeah, it's getting a bit fragmented, right? So you can go to a pharmacy and have a consultation with the pharmacist, and they can push you an injectable, and they can use their tie-up with an online provider and give you a script. Same thing with medicinal cannabis. There's just heaps of online platforms out there, so you don't have to actually see your GP. You can see somebody else, and the care becomes a bit fragmented. So the GP is probably not the center point of the caregiver these days, because the care is getting fragmented. But again, GPs are very quick in adapting to that. So there are more face-to-face consultations available for these kind of services, like weight loss and medicinal cannabis and so on. But like Nazmi referred again, GPs are trying to specialize in different facets, because they're just sometimes sick of seeing sinusitis and tonsillitis and shoulder bursitis. They want to, use their skills and hone it in a specific specialty. But I still find that about 50 to 60% of our workforce with GPs, they are happy to do, all of these things and still be the usual go-to GP. It'll be interesting to see how these things evolve in the next 5 years.
Well, look, that brings on time. So thank you very much once again, Vishnu and Nazmi, for coming on and sharing your perspectives with everybody. And yeah, thank you very much.
Absolute pleasure.
And Liam, I don't mind you sharing my email address with the attendees. If somebody wants to, ask me anything specifically, more than happy to respond. But give me 2 days to respond, though.
No problem at all. No worries. Thank you very much.
Awesome. Thank you very much, everyone.
Thank you, guys. Bye.
Bye bye.